All right, let's get going here. Hi, my name is Dr. Naftali Serrano. I'm the Chief Executive Officer of the Collaborative Family Healthcare Association. And I'm happy you're with us, whether you're live or whether you're watching this on our recording feed on integratedcarenews.com. I usually try to introduce CFHA at these video recordings / webinars. Just for folks who are out there who may be watching this for the first time. CFHA is a nonprofit member association that's dedicated to promoting the integration of physical and behavioral health care across the health system and across the United States. We are really passionate about making healthcare make sense and work best, both for our patients, their families, our communities, and for the healthcare workers involved in the provision of healthcare. So if you're interested in this mission, definitely check out our website, CFHA.net. It's CFHA.net. Now today we've got a great webinar. I'm going to let the webinar folks introduce themselves and introduce their topic here. But we cover all sorts of different topics at CFHA, from practice-based topics to system-oriented topics. And what's awesome is we also have a great group of folks who are really dedicated to research and to making sure that the research that undergirds our work is both relevant, practical, useful, and helps guide our practice efforts as we look to transform the healthcare system nationally. So a couple of quick things before we turn it over to our presenters for today. If you could move the slide forward. We've got a conference coming up, so if you're watching this video past October 17th, I apologize, you can't come retroactively to our great conference, but we do have a conference October 17th through the 19th in Denver, Colorado. To find out more information, where you can hang with the kind of people whom you will hear here in today's presentation. You can just go to integratedcareconference.com. That's integratedcareconference.com, one of our other family of CFHA websites, and check out the incredible programming. And some of the folks here, in fact, are presenting at that conference as well. And if you're watching this video past the October date, no worries. If you go to Integrated Care Conference, you'll find out about our subsequent annual conference, which will be in Philadelphia in 2020. Now, at our upcoming conference, we do have a special event on the Sunday of the conference that we want to alert you to. So this is a separate registration that's done in collaboration with an external agency that's hosting this forum called the Primary Care Behavioral Health Community Forum. The information is there on your screen. It's an opportunity for folks interested in what's called the PCBH model of care to come together, get updated on the research, and share their stories. So for more information, again, go to integratedcareconference.com, and the link to register for that separate event is there. Okay, so that's all we need to know about CFHA and our upcoming conference. Now let's turn it over to our vaunted panel.
Awesome. Thank you for that introduction. And this is Jody Palaha, and I'm just pulling up our slides. Thrilled to be here today with my colleague, Dr. Keely Pratt. We are on the editorial team for the journal Families, Systems, and Health. And if you're a member of CFHA, you'll get free access to that journal because that is the official journal of the organization. And what we hope to do today is provide you all with an overview of what our journal is thinking about days, give you a little bit of a sense of what it takes to publish material in the journal, and then lastly, give you a whole bunch of ideas about how to get more involved in scholarly work. We don't have any disclosures, and just very specifically, we'll talk a bit about research papers that fit our vision, what the peer review process is like, and then again, a bunch of opportunities that are out there if you're interested in developing yourself as a researcher, program evaluator, or just doing some scholarly work. This is my colleague, Nadia Sundarji. Dr. Sundarji and I are the co-editors of the journal, and our full editorial team includes the two of us, our three associate editors that you see here. Dr. Pratt is in the middle, and she's the person who will be providing this lecture with me today. So the five of us meet regularly, and we have, in addition, we have several department editors, and we'll talk a bit more about the different sections in our journal and other opportunities that we have for publishing in our journal besides traditional research papers as we go through the talk today. But before we get into those specific logistics, I wanted to spend just a minute telling you what this journal is about and what our vision for the journal is. This journal has been around for a few decades now, and its origins are in the area of families and systems as those interact in healthcare. And so you see these three domains listed here: family functioning, systems thinking, and healthcare. Those are the kinds of things that go in the journal. And really, basically, when we see a paper and someone asks us if this is relevant or it's been submitted to the journal, we always ask whether the paper has content that covers at least two of these three domains. So if it's a families and systems paper, great. If it's a families and health paper, great. If it's a health and healthcare systems paper, great. 2 out of 3 is sort of the basic rule of thumb for assessing whether the content of the paper broadly fits with the journal's mission or scope. When Dr. Sundarji and I took over the journal a year ago, well, it wasn't even. Our first editorial was last December, so we're coming up on a year here, but we're really only at about 9 months. We developed a unique mission for the journal that sort of extends beyond the three sort of domains, families, systems, and health, to sort of cast this idea that we wanted to increase the numbers of articles that relate to implementation and dissemination activities. So this bridge actually is an illustration that shows sort of the mechanisms that support science and how the products of science move. So if you look at the far left, that's where basic science lives. And those are the studies that evaluate how things work in the world, the origins of phenomena, how they relate to one another. And as you move across the bridge, you start getting into how you use those findings from basic research to develop interventions or sort of put 2 and 2 together, programs and development ideas. And so you've got a bridge there too that consists of journals and grant mechanisms and research methods, the science infrastructure of science that supports the development of products of science, right? They're moving around on the bridge. And as we get to effectiveness studies and efficacy studies, what you see is that the bridge is not very well developed. It doesn't connect very well, not totally complete between the far right portion of the bridge and the shore. And many of the people that we feel should be empowered to produce science and contribute to science are actually clinicians and administrators and people who know a lot about policy, who are standing on the far right, on the shore. And what we want is to empower those folks to help build the bridge, finish that connection by sort of experimenting with methods in real world research, or take findings that are coming from the middle part of the bridge and see how do they work in the real world, and do some real world research on implementation or dissemination of evidence-based treatments. So this is sort of the far right there where the gap is where we really hope to focus the efforts of our journal and where we're really trying to recruit studies. And here are just a few examples from recent years, and actually two of these appeared in our first issue. One came even long before we were editing the journal. But you can look at those titles and see how they might be good examples of sort of real world research. The first one is interesting. It looks at electronic mental health screening and measurement. And it's actually sort of a methods study. It's sort of looking at the actual bricks and steel of the bridge itself. How do we build methods that can bring evidence-based practices into real-world settings? We all know use of electronic screeners is helpful and useful and kind of coming up in primary care-based work. So how could this method be helpful? Then below that, you see a rural study. Certainly that represents a place out beyond the bridge, somewhere on the road, on the far shore. And then below that, a practice management and billing study. So I wanted you just to see a few examples. And now Dr. Pratt will talk a bit. She and our other associate, well, all three of our associate editors are strong in the area of families science. And Dr. Pratt's going to speak a bit about how the journal continues to focus on family science.
Great, thank you. So family science in general, I think it's important to situate what family science is and how it fits with the journal and what the journal uniquely is hoping to contribute with respect to family science. So family science has been around for quite a long time, and it's an interdisciplinary approach to the study of families, and most importantly, not just inclusion of families, but inclusion of the measurement, the assessment, and actually monitoring close interpersonal relationships through intervention design. And this is really what situates family science apart from other scientific inquiries that look at families or couples or parents or children. It really is the interpersonal dynamics that make this quite a bit different. So studying what happens between people, not necessarily just within one person. So this in large part moves beyond some of the traditional mental health, behavioral health realms, and while incorporating those aspects also includes some interpersonal dynamics. So as applied to family systems and health, we get traditionally a pretty good depth of articles that focus on family science and historically have. We have quite a wealth of articles that focus on a lot of correlations and relationships between family variables, and I'm using that very loosely on purpose, and a healthcare outcome. So for example, we get quite a bit that might look at parenting dynamics and weight management, or parent-child conflict and asthma management. So that's something that you probably have seen quite a bit of work that's been published in family systems and health. And so what we're trying to do is continue to publish those high quality, rigorous studies that are cross-sectional and correlational, but like Jody mentioned, or Dr. Paula mentioned with the bridge, is really kind of moving to more of this in implementation and an intervention design as well. And so before that happens, we're really interested in also looking at family science and longitudinal studies. So a lot of the work that's done with family science tends to be cross-sectional, in large part because there's not a lot of evidence with how family variables change over time in relation to health variables. So for example, a lot of family science variables that are measured, like parenting, like relationship satisfaction, tend to be done at baseline and then controlled for longitudinally, or used as predictors of an outcome longitudinally. So we're really interested to see submissions and to further publish things that look at family science variables of interest over time in combination with health outcomes as well. And then thinking about intervention, family-based interventions, you probably hear this word a lot. It's very popular and very in vogue to say right now, but it's not necessarily well defined all the time. So, excuse me, at its simplest form, family-based interventions are the inclusion of at least a family member in a patient's intervention. But that inclusion can take a lot of different shapes, right? So it could be actually including that person in assessment only, or including that family member, that person actually in intervention content. So we're really interested in being able to have more family-based interventions and really being able to flush that out also for family systems and health in terms of the variety that we see with family-based intervention. As family-based intervention relates to family science, like the gold standard would really be to be able to assess interpersonal dynamics with these family-based interventions, but we know that that may not be possible, and certainly maybe taking a leap for certain content areas if there's not a lot of evidence in whatever interpersonal dynamic you may be assessing for your population of interest. And then, you know, moving down towards the bridge that Dr. Paula put up is we're really interested in looking at how family-based intervention, which is representative of family science variables, looks in integrated care settings. So, you know, in settings where we have integrated behavioral health care, what kinds of family dynamics, interpersonal relationships are being monitored over time, and how can those things be improved, or how can those things be assessed to improve health outcomes ultimately? Can you flip to the next slide, please? Oh,
Sorry, Kaylee, I'm trying. Hold on.
okay, you're good. I'm just going to keep talking, no problem. Some examples of family science manuscripts. I wanted to provide kind of a context for the variety that we see, because we do get quite a few submissions and we do publish quite a bit with respect to family science in the journal. So one thing that is exciting is seeing some of the innovation in methods. So kind of moving beyond this correlation and even some of the causation stuff that we see, to taking some of the traditional methods and amping them up, for lack of better words. So here's an example done by Didrikson and colleagues, very recent, that was published, and it uses triadic data to look at the association between mother, father, and adolescent concordance and discordance on home environment factors and unhealthy weight control practices and behaviors. So this is taking something where quite often we see things about parent-child agreement or partner-partner spousal agreement, but this is something that has moved, or a particular approach that has moved beyond and look from dyadic to triadic. So this is an example of, it is a cross-sectional study, which we get quite a bit of, but it's using triadic data, which is very innovative for this area. Next slide, please. And then moving along, an example of an association or a longitudinal study. This is by Tully and colleagues, again, fairly recent, 2019, and looking at asthma and, pediatric asthma, and exploring the relationship between parent-child psychosocial functioning and asthma-related health outcomes over time. So again, this is looking at interpersonal dynamics through the psychosocial functioning screeners that they used and assessments, and how those things relate to asthma outcomes over time. So this is a great example of a longitudinal article or manuscript that we get that really fits within the family science hub. Next slide, please. And then finally, I wanted to provide an example of an intervention manuscript that has been published in Family Systems and Health. This one's a little bit dated, but I think it's a great example to illustrate the point. This was they called it the Today Intervention Treatment Options for Type 2 Diabetes in Adolescents and Youth. And this was a randomized controlled trial that randomized adolescents with type 2 diabetes and their parents and guardians. And they looked at the relationship between family conflict and type 1 and type 2 outcomes over time. So again, this was a great intervention example that includes family members and also assessed both members' perspectives over time in an intervention. All right, and so now moving ahead, those are some examples of different articles and manuscript content that we have in the journal. Now let's move to the peer review process, and we're starting a little bit early with, in general, what's the publication process, not just the peer review process. So if you look at the next slide, you're going to see in large part a very long, not easy to read timeline for publication. But this includes most relevant components. So before we even think about publications, before they come to us as reviewers and before we're working on them as researchers, it's really important to think about where our ideas come from and how our ideas come to us. And that's where that kind of spotted circle that you're seeing on the left side of your screen. So for example, vetting your ideas through colleagues, through patients, through clients, through advisory committees, through students. It's really important to figure out how your ideas situate within the larger, broader area of research that you're part of. Then it's really important to think about the ethics of your idea. So, for example, not all ideas may be readily available to do at the current time. So thinking about human subjects' concerns, who needs to be involved, what kind of permission needs to be obtained, are things ethical, are things equitable, and what kinds of things need to be controlled for in your study. So, quite often this is where investigators are seeking institutional review, board approval prior to starting their work. Both at traditional medical centers, also at academic units. Then goes, you can see progressing over to the right, your data collection methods, whatever that may be for whichever study, whether it's secondary data analysis or primary data collection. And following data collection is your data analysis and synthesis, and heavy emphasis on synthesis and making sure what you're finding fits within the larger body of work that it needs to be situated in. So for our journal, that's thinking about how your findings situate within family functioning, so what's happening within the family context, within health and health outcomes, and within systems, whatever systems those may be for you, healthcare systems, school systems, et cetera. And certainly with data collection and data analysis, we want to make sure that this is all done with evidence-based practices and as rigorous as possible. And when methods aren't rigorous, some kind of justification as to why perhaps, for example, if it's the first time you may be exploring a topic that doesn't have a validated questionnaire for use, that would make sense that you may be developing your own questions, but that has to be justified. Following data analysis and synthesis is presenting your findings initially to a group of peers. And so that's often done through abstracts and presentations. You can get feedback on your work and again, figure out how your work is received by a larger body of people. And then leading into manuscript development. So based on how your work's received, are there any edits or any tweaking you want to make to the interpretation of your findings or the presentation of your findings, and then developing your manuscript collaboratively with your co-authors, and then submission. And so we're going to really go through the manuscript development and submission process in the next slides. So I'm going to scoot through those. And following submission, you hear back in a very timely manner about whether your manuscript is accepted, whether it's accepted with minor or major revisions, or whether it is not accepted. And then that determines whether publication will be in this journal or in a journal elsewhere. All right. So the publication process, I mentioned this at the beginning, is really where do your ideas come from? And so for those of us who are science practitioners on the phone, it's really, we're lucky in large part because a lot of our ideas, and I can speak for myself here, come from the patients in which I work and the collaborators in which I work in healthcare. So, many of the ideas I have are practical solutions to things that may be going on with patient flow, or maybe going on with an assessment that needs to be included for a certain outcome that we're monitoring. So it's important to think about the roles of being a clinician innovator. So using that practitioner lens to inform your science, as well as the role of quality improvement within the site that you're at and what kinds of outcomes you're assessing to improve quality of services that are delivered. It's great to be able to collaborate with people that are inside your discipline, but also outside your discipline. So both inter and multi-collaboration. So for example, a lot of people in healthcare where I work collaborate with traditional academics, and academics collaborate with traditional healthcare researchers. And that only benefits both sides because you're able to run your ideas by both kinds of ends of the continuum. So importantly, when you're thinking about these ideas, if they stem from your clients, your patients, healthcare in general, quality improvement, it's important to ground these ideas and the evidence that has been generated for these ideas over time in the content area. So making sure to do appropriate literature reviews and searches, making sure that your ideas actually fill a gap in the literature or further an area that needs to be developed in the literature. That's really important when you're situating your study. And of course, vetting your ideas with collaborators from the start. I work with a lot of surgeons, and ultimately, like when I'm working with them, they want to know, how is assessing family relationships going to help my patients have fewer readmissions post-operatively? And I'm like, that's a great question. So it's important to think about your collaborators are a great resource to help situate what you're doing in multiple disciplines and settings. And then certainly, because family science is a fairly saturated area, to make sure that there's innovation in what you're doing. And that innovation could take a lot of different forms. So it could be the population you're working with, it could be the methods you're using, it could be the findings that you have that may be novel, but you need to be able to spell that out for us so we understand what the innovation is, because like I said, family science tends to be fairly saturated. All right, next slide, please. So in terms of the publication process, the first step is manuscript development, and depending on what kind of article or manuscript you are developing will depend on how you format it. So for example, in family systems and health, we take several different types of articles. We take research articles, which are probably like the bread and butter of what you think about traditional manuscripts. They're up to 3,500 words. We take brief reports, which are 1,500 words, review articles, which are 3,500 words, conceptual articles, which are 3,000 words, and then there are commentaries and replies, which are slightly less, about 1,000 words. So it's important that when you're thinking about what kind of article you're going to write, is it based on data you have? Is it based on the conceptual model that you're making? That you go ahead and you look at the journal's guidelines for those particular manuscripts before you get going. So you're writing to format rather than having to go back and format things after you've already written. In terms of writing support, writing support can be sought at multiple levels, both from peers, also from mentors. It's great if you have colleagues that also review for journals and to be able to have them review your manuscript. Have people who are experts on the content review your manuscript too. So people that are strong writers and strong empirical writers, but also individuals that have a strong background in the content area as well. And then depending on where you're located at, many universities have, and medical centers have writing centers that can help with manuscript development as well and vetting. All right, next slide, please. So for reviewer guidelines, that was just a brief overview of the manuscript development process. Once you are a reviewer, or if you're interested in being a reviewer, we're very mindful of being equitable to authors and ethical to authors. And so all manuscripts are confidential. So they shouldn't be, once you are a reviewer, they shouldn't be distributed or discussed with anyone during the review process, which is a very rigorous process. Right now they're single blinded. So the reviewer has access to all author names, but the authors don't know the reviewer's identity. This is beneficial in some ways and not in other ways. The ways that this is beneficial is, people who submit to CFHA may tend to know each other. That's not always true, but certainly if there's a conflict of interest, like for example, if my former advisor were to submit a manuscript, I shouldn't be reviewing that. With that, we expect clear and concise writing of the manuscripts, and that each section of the manuscript should be understood by a general audience. So because CFHA is an interdisciplinary journal and a multidisciplinary journal, we would like manuscripts to be understood by both practitioners as well as strict researchers and people that go back and forth between those two. So overall, we want to provide honest commentary about the quality and the novelty of the paper and the interest to the readership. Next slide, please. So when providing a review, often and if you've never provided a review before, you can always contact the journal too. I know I have several examples that I have permission that are saved and a general template that I use when I do a review that I'd be happy to share. But generally, this is what needs to be covered. It's a brief summary statement about the content of the manuscript. So this is like the very first paragraph or short sentence or two you might see at the beginning of a review about the overall kind of impact of the manuscript, for lack of better words. And then your review needs to be focused primarily to the authors and directed to the authors. This should be a professional and constructive tone. So the goal is to be able to provide authors with helpful information that can further their research. And so because you're trying to help them further their research, it should be constructive and not, this is unacceptable. It needs to be more, here's how this could be acceptable. So it should be honest, it should be overall kind. And your overall opinion of the paper in terms of recommendation or rejection or revisions should really be detailed in comments to the editor, not comments to the author. So in our submission system, there's a box for the editor comments, which does not get sent to the author, and there's a box for author comments, which the editor can view. So anything that's perhaps more critical than what an author needs to see, or any determination of acceptance, rejection, et cetera, should really be in the comments to the editor. Concerns should be clearly identified, and when possible, concerns should be, after each concern, there should be an area about how that concern may be able to be addressed if the reviewer knows that. So again, we're looking for things to be constructive. In terms of commenting on the quality of the writing, those can also be commented to the editor, or if it's more like typos, grammatical, that can be listed generally with examples that are provided. And then the editors and the associate editor's job is really to make sure that the readership is going to be interested with the topic of the manuscript that was submitted. So it's important for the reviewers to think about, does it hit on family functioning, does it hit on health, and does it hit on systems? But it's also the editor's job to make sure that the content of the manuscript fits with the readership. All right, next slide, please. So breaking this down even more, in terms of the title, it's important to make sure the title reflects the actual content of the paper. And certainly as a reviewer, it's part of the responsibilities to determine if it does reflect that and to suggest revisions if it doesn't. Second, does the abstract concisely and accurately provide the overview of the paper and the main findings? Typically where the most hangups come with this is in the conclusions area of the abstract. So the introduction or the background, the method, the results, and in my experience, those tend to be pretty clear, but sometimes the interpretation of findings, that's often the sentence that may need to change to be more accurate and not so generalized. And then finally, the introduction. So do the authors provide a concise review of relevant literature? Is that literature current, meaning like in the past 5 years or 10 years, depending on whether it's a conceptual paper, whether it's an empirical paper? So up-to-date references and primary sources are always preferred. And then really making sure that that gap that I mentioned before is identified. So is this study, is this inquiry providing something novel that can be consumed by the readership and that can be helpful in filling some kind of a existing gap that's there? Next slide, please. With respect to methods, it's always important to determine if the methods are rigorous and if they're appropriate for the topic of inquiry. And for family systems and health, we take a variety of methodological papers. So we certainly take qualitative papers, quantitative papers, mixed methods papers, multi-method papers as well that aren't just mixed but are multi. And so making sure that the method that is used is justified and is appropriate. Also making sure that there's always identified a human protection or human subjects protection statement, so institutional review board or the equivalent, depending on where you're at. Adequate description of the methods, so especially when we see papers from larger randomized controlled trials or interventions that often reference other papers that may talk about the methods, making sure that there is still enough information about methods that they can stand alone in the current manuscript. So again, making sure they're described and adequately described, and if anything is innovative with those methods, noting why it's innovative and why it's being done differently. As a reviewer, there should be, if your particular expertise is not in whatever statistical analysis was used, making sure to know if there's a need for a specialized statistical review. Making sure that the sample size is justified by the authors that are submitting, and whether that's through a sample or power analysis or prior work that's been done with the same population or type of design. And then for systematic reviews, making sure the authors describe a reproducible strategy to conduct the review. And arguably this would be for literature reviews as well. So systematic reviews, meta-analyses, of course, this needs to be included. But even for literature reviews, there's a push to really make sure that the literature that was reviewed was done in a rigorous manner as well, with some kind of a diagram pictorially representing that or text that does. Next slide, please. And then looking at results, making sure relevant demographics are described in text or in table, making sure that all result tables are standalone as well, and that the tables can be interpreted fairly easily, and that the results logically flow from the actual purpose of the project and are clear and focused. So whether these are figures that are used or whether these are tables that are used, making sure they make sense with the actual text results that are provided, making sure that things aren't redundant heavily from tables to text, or that are redundant heavily from, I'm jumping ahead a little bit, from what's provided in the results, also in providing those same results in the discussion, which often we see too. So making sure the discussion is a discussion of the results and not reporting of the results again. With the discussion, making sure that they have application to practice as well as to systems or families. So because the readership of the journal is very practice-oriented as well as research-oriented, making sure that manuscripts can speak to both. It's important to think about the limitations that are involved and that they're accurate and that they're comprehensive. So limitations with the population, limitations with the method, limitations with the generalizability of the findings, with the analytic approach. So when thinking of limitations from a reviewer lens, really thinking about all the main components of the manuscript and what are the limitations of each. And for conceptual papers, really making sure that the literature review is very thorough and comprehensive, and that the model isn't duplicative, but advances and allows practitioners and researchers to think about something in a novel way to enhance clinical practice. And the next slide has the manuscript rating form. I apologize, this is pretty difficult to see, but in terms of what's on here, this is rated. The reviewer rates this on a scale from low to high, 1 being low, 5 being high, with the not applicable indication as well. about the appropriateness for the journal, the significance of the issue, interest to readership, quality of research with design and analysis, although that's combined into one, the adequacy of the data, the interpretation of the data, the quality of the writing in terms of clarity and style, coverage of the topic, so in the literature review, how well is it covered, and the relevance and adequacy of the literature review that is covered, and then contribution of new knowledge and the utility of tables and figures. So we ask that reviewers indicate on this, and we do pay a lot of attention to this. Obviously, there may be some not applicables if there aren't any tables and or figures included, but that informs the overall rating for the manuscript too, which is given typically, Jody, remind me, this is given on a 1 to 10, is it 1 to 100 scale or 1 to 10 scale?
It kind of varies in the EM. Actually, we've been working through some glitches with that, but yeah. So I was going to just add to your comments that this is a nice list of things that reviewers can focus on in their review. Sort of helps you remember all the points that you should be thinking about as you're reviewing a paper. But it's also kind of a nice list if you're an author and you're writing a paper and you sort of can see here sort of the general areas by which you'll be evaluated and consider those.
Mm-hmm. Absolutely. Thank you. So when you are reviewing, or if you're submitting and getting this feedback, you will, if your article is accepted outright, fantastic. That's what everybody dreams of. If it is accepted, or if it's not accepted, but with revisions, either minor or major, and being able to look at those revisions, it's important to think about these, that the feedback is constructive and to interpret it as constructive, not what does this reviewer know about this? So to really be able to take in an outsider's viewpoint on the manuscript to make the manuscript better. Often we're so close to our own work that it's hard to see the limitations of it. And so these really are gifts to be able to think about something broader than what we may be able to if we're so close to it. So in revising manuscripts, it's important to, well, one, it's important that the reviewers are very clear in their feedback, so then the authors can address those in an itemized way. So listing the reviewer and how they've addressed it in the manuscript, or if they can't address it or don't agree with it, to be able to document and provide evidence for that and the rationale for it. So then manuscripts are typically revised, and then they're resubmitted, which ultimately determines whether they may need to go under another revision or whether they may be accepted or rejected or whatnot. So common concerns that we often see are weak, particularly for family systems and health, are weak on implications to health or healthcare, not being able to situate the purpose within the literature, or not being able to build on the current literature with the purpose. So often manuscripts may have skipped a step or two rather than logically flowing from what's already there. Qualitative methods with lack of rigor. So, a big push in qualitative methods is being able to use software now that will help with analysis, that provide frequencies, percentages, and provide more rigor to how many participants said what and what constitutes as a theme or a category. Unethical or poor use of citations, again, making sure citations are up to date and that institutional review board status is documented and approval. Weak overall methods, so methods that weren't well constructed from the beginning, it's hard to overcome that. And then actually being able to think about submissions, providing the context for the data that's provided. So often we get these big projects, or we conduct these big projects, and we may be slicing the manuscripts too thin, meaning getting the most bang for the buck in terms of publishing multiple manuscripts rather than one or two from a study that may be more comprehensive. So really making sure that there's value added with the comprehensiveness of what's included in a manuscript. Other common concerns are poor writing. Certainly this can be fixed to some degree with grammar with wording, passive versus active voice. And then the biggest concern, I mentioned this before a little bit, but is ethical violations. So making sure that the consent process is documented for human subjects, that IRB or review board status is documented, especially when working with underrepresented or minority populations, that materials have been validated for use with those populations, and that ethics are maintained. All right, and so if you're interested in becoming a reviewer, you can email Dr. Bohala or Sundarji and express your interest. You can provide your CV, and if approved, onboarding will be done through the coordinator, Cheryl Johnson, who's amazing and always on it. And we'll make sure you'll indicate within the system your expertise areas. So ideally, papers that are forwarded to you to review will be within your wheelhouse of interest. All right, Jody, I'm going to pass back to you.
Nice work, Dr. Pratt. You did a great job giving everybody a good sense of the family science side of the journal, as well as kind of the details involved in submitting and the review process, which is really what keeps the science honest. And we rely on our reviewers and our own abilities to review. Now that's our mechanism. That's how it works. So now, we're hoping that folks will be interested in getting involved in scholarly work, but perhaps you don't have a large grant or the ability or time cut out of your schedule to conduct a huge study. What I'd like to do is run you through some different kinds of things you can do to be involved in research or evaluation or scholarly work that could appeal to you. So certainly we would love to have you submit an empirical paper. And as you heard Dr. Pratt saying, we have multiple different formats for that that have different requirements. These are all the different kinds of things we have. But look at the bottom there, and I want to make sure you notice that it says we do pre-submission consultation. Now, if you've written a paper that is kind of cut and dried and it's done, then we'll probably just have you submit it. But if you're designing a study or you've got a whole bunch of data and you've got some ideas about how to write it up, but you're not sure, we're happy to consult with you, particularly if your project is a fit with implementation and dissemination research, and give you some pointers as to sort of theoretical models you can use to base the study on, or other ways to strengthen the way that it comes to us in manuscript form. We want you to know that right now we have a call for papers out. It's a special issue that is being developed by one of our associate editors and a few others on our editorial board, and it will focus on informatics, specifically collection, analysis, and application of data for direct care decisions in healthcare. You yourself use data through, say, the EHR or other healthcare metrics like that. If you want to contribute to this issue, I would encourage you to reach out to our guest editors. And I'm giving you lots of names of people. I'm going to give you a website at the end, as well as emails that can direct you to all these people. The other thing you can do, if you don't have a science project going right now or a program that you're evaluating, and you don't have an empirical paper, but you'd still like to do some scholarly work, is you can submit to one of our other departments. We have a Humanities Department where we collect narratives, poetry, and 55-word essays. We have a media review department, and we're very interested in your review of a good book that you've read that relates to families, systems, and health. Perhaps it's an app or some other kind of media. And we also look for policy and management papers. We have a very strong section in that area as well. Here's a couple of call for papers that we have out. One is for book and media reviews. This gives some examples and talks a bit about what that looks like. Again, I'm going to give you a link at the end here so you can find all of this online. The other call we have out right now is for a paper in the policy and management department. Very interested in health policy and also kind of basic practice management issues and how those are happening in the current environment. Another thing we're looking for right now is a co-editor to help curate our Humanities Department, which is called Sharing Our Stories. We have a very seasoned editor, Dr. Jo Riley. She has many years of experience, and we just lost another is retiring, another very seasoned editor, Dr. Johanna Shapiro. So we're looking to try to fill her shoes. And again, with Dr. Riley on board, we have a really great mentor for someone who might come on and help us edit for that department in our journal. All of these calls and email addresses for all of these people you can find at our website, which is listed here. And there's a picture of our journal there on the left. This is where you find us. You can also find us on CFHA's website because, again, we're the official journal of CFHA. And in fact, if you're a member of CFHA, like I said, you get us free. Thanks to the work of Dr. Serrano, there's a one-click process. So if you are in CFHA's website and you're a member, you can just click one button to get to the latest issue or any issue and look through articles there. We're going to be at CFHA in Denver, and we'd be happy to meet with any of you. You can schedule time with us or plan to meet up with us, but we're also planning on having some consultation times set aside, and you can find out about that when you start preparing for the conference. We're also doing a pre-con, so the day before the actual conference, we're having a 4-hour or so extended learning opportunity and program evaluation, and we would invite you to join us. Dr. Sunderji and I will be joining two of the leaders from our Research and Evaluation Committee, Dr. Shepardson and Dr. Funderburg, and guiding participants through the process of conducting a program evaluation, specifically focusing on measures and methods. And we're really having people turn in information in advance and doing all kinds of things so that we can tailor this learning opportunity to the folks who show up for that workshop. You can also see us in a lot of other places at the conference. One thing you might want to learn about is the Research and Evaluation Committee in CFHA. Their job is to promote research and program evaluation throughout the organization. That group will meet at 7 a.m. on Friday, October 18th. In addition, every session, every breakout session during the conference has a research and evaluation training track. And you'll see when you look at the sort of program in a day schedule that there's one section that's always about learning how to do research or program evaluation. So every single breakout, you could go to one of these lectures. And I just gave you an example of some of the topics. Learning how to, it should say the EHR, right? Learning how to use data EHR. Learning how to study provider impressions, attitudes, beliefs, responses to programming. Learning how to evaluate relationships in systems and families. Learning implementation science methods. Those are all different kinds of breakouts, and there are more. Do you want to tell folks real quick what your breakout is? Because you're doing a training for the research and evaluation track.
Sure, yeah. My student, my doctoral student, Katie Van Fossen, and I are doing a session entitled Moving Beyond Behavioral Screening and Assessment. And what we mean by this is behavioral only screening and assessment, and making the case for relational screeners, assessments, and outcomes in integrated care settings. So, I mean, directly in line with what you've been talking about measurement and assessment, this particular session will focus on utilizing evidence-based screeners that assess interpersonal dynamics and relationships in combination with behavioral screeners that are commonly used. So if we're assessing depression in adult patients, how can we also assess relationship satisfaction, and how can those things be utilized within primary care and specialty care settings. So we go over the evidence for that that's been done conceptually, how that makes sense, and some exemplars of our own work and how this could be incorporated into different kinds of healthcare settings.
Great. And I'll be doing one as well with several different colleagues to talk about implementation science and how to establish in implementation research and learn where you are best positioned on the translational bridge and can make a contribution. It's going to be fun. The other thing that we'll have this year, in addition to having a regular poster session with lots of great projects, is a guided poster walks where myself, Dr. Sunderji, and Dr. Funderburg will be walking people through and talking about some of the posters that are in the session. I would also encourage you to look ahead to Halifax. In June, the Canadian Collaborative Mental Health Care Conference is the Canadian sort of version of CFHA, and they run a wonderful conference every year in June all over the country, and this coming year is in Halifax, and CFHA listserv does push out information on that as well, so you can keep your eye out. This is us and our email contacts, and I appreciate the opportunity to talk about what we're doing in the journal, and hope to hear from you soon. Thank you so much.
And thanks so much to Drs. Palaha and Pratt. Thank you guys, that was fantastic. There's a plethora of resources that you have at your disposal. If you're a hardcore researcher, or if you are new to research and sitting on data or sitting on a great idea, please reach out to us at CFHA, reach out to Drs. Palaha and Pratt. There's lots of connecting points for bringing that data and those ideas and pushing the science forward for the community. Thanks again, and we hope to have you join us again, either on integratedcarenews.com or on any of our live webinars. All right, thanks so much, guys. I really appreciate it.
Yeah, thank you.
All right, we'll send out the link.